Hello, and thank you for joining us today as we discuss hyperkalemia. Health services across Manitoba are This presentation is intended as general information to broaden the knowledge base and informed practice of paramedics across shared health. The goal is to ensure paramedics can utilize the knowledge gained and apply it to any patient care map updates. So today's discussion will be about potassium and its functions within the body, including some A&P review, pathophysiology, clinical presentations that we might expect, and how we will manage. So to start our A&P review, we will go over the smallest of the human body components, which is cellular activity and the electrolytes, specifically potassium. So no surprise that we're talking about potassium today. The word kalemia means the presence of potassium in the blood. Potassium has many roles within our body, but today we're going to talk about when there is too much potassium in the blood, hyperkalemia, and what it does to the body and how we can help. Where do we find potassium in the body? So we'll start looking at the body's fluid compartments first, and there is both intracellular and extracellular fluid compartments. And then the extracellular compartment is divided further into interstitial fluid and blood plasma. So we're not going to look at all of the electrolytes, but focusing on potassium, it is found predominantly within the cells or intracellular fluid at almost 90% of the total body potassium, and the other 10% is found extracellular. This is ideal for maintaining normal body functions. You may also notice that the sodium is predominantly extracellular, and we'll discuss this reason why in a few minutes. Now looking at the human cell itself, how does potassium maintain its intracellular presence? Here we really want to look at the cell membrane. This is where the structures are found that help maintain homeostasis. Here along the cell membrane is where basic cellular functions take place. This is such as cellular metabolism, transport of substances, cell reproduction, and communication occur. The communication process is what we'll be focusing on. Communication can occur between cells, its surrounding environment, and between other cells as well. And this is carried out by various methods, including a chemical and electrical signal exchange. The chemical signal, which are proteins and other molecules produced by a sending cell, are often secreted from the cell and released into the extracellular space. There, they can float like a message bottle over to the neighboring cells. Looking closer at how signals are sent from one cell to another, the cell's ability to communicate is facilitated by receptors and channels found along the cell membrane. They allow specific molecules such as ions, nutrients, wastes, and metabolic products to enter and exit the cell. This will help mediate cellular and extracellular activities. Ion channels are pore-forming membrane proteins that allow ions to pass through the channel pore. So why do we need to know this? So that we can discuss how potassium moves within the body fluid compartments, specifically by the sodium-potassium pump. This is a mechanism of active transport that moves potassium ions into and sodium ions out of the cell. This pump allows the proper movement and balance of water between the intracellular and extracellular spaces. It does require ATP or energy to work properly, and the job is to help maintain the resting membrane potential. The sodium-potassium pump binds 3 sodium ions and a molecule of ATP or energy. The splitting of ATP provides energy to change the shape of the channel, and the sodium ions are driven through the channel. The sodium ions are then released to the outside of the membrane, and the new shape of the channel allows 2 potassium ions to bind. The ATP molecule or phosphate is released, and it allows the channel to revert to its original form, and this is when potassium ions are released on the inside of the membrane. Going back to what potassium does for the human body, it's a mineral that is needed for all body tissues. It's referred to as an electrolyte because it carries a small electrical charge that activates various cells and nerve functions. Potassium is necessary for maintaining fluid and electrolyte balance, as well as pH levels. Then sodium, its counterpart, maintains normal fluid levels outside of the cell. Normal potassium levels are kept between 3.5 and 5.5 milliequals per liter, and this normal balance is maintained through excretion from the kidneys. So potassium is supportive of the nervous system by playing a crucial role in normal function of the nervous system. It helps nerve impulses fire by moving in and out of the cells. Potassium helps maintain fluid balance inside and outside of the cell for optimal health, and potassium is a key electrolyte that helps maintain this balance. High blood pressure can be alleviated by eating foods high in potassium and reducing your sodium intake, and therefore a balance is restored and it helps reduce blood pressure. Supports bone health. Potassium reduces bone reabsorption, which is the body's process of breaking down bone structure. So over time, potassium contributes to stronger bones. Potassium regulates muscle contractions. So as a muscle contracts and relaxes in response to the nerve impulses, because the potassium is moving in and out of the cell, potassium is needed for those impulses to fire. So when you have or are experiencing cramping, there could be a deficiency of potassium. It also supports the heart rate. The contraction and relaxation cycle of the myocardium depends on potassium. The same as the rest of the body muscles react to potassium-driven nerve impulses. So these last 2 points are key in understanding is what is happening when there is too much potassium in the bloodstream and not intracellularly. Looking back at the balance between potassium that is found predominantly intracellularly and sodium, which is found predominantly extracellular, hyperkalemia develops when there is excess production. Production could be through oral intake or tissue breakdown, and it can also develop when there is ineffective elimination of potassium. This excess production or ineffective elimination now causes the sodium-potassium pump to stop working effectively. There's no longer any movement of potassium into the cells, and this leads to an excess amount of potassium in the bloodstream. This is hence the name hyper, which is a medical definition for above normal, and kalemia, potassium in the bloodstream. Increased extracellular potassium levels, or potassium in the bloodstream, result in depolarization of the membrane potential of cells. This is due to the increase in the equilibrium potential of potassium. This depolarization opens some voltage-gated sodium channels, but it also increases the inactivation at the same time. Since depolarization due to concentration changes is slow, it never generates an action potential by itself. Instead, it results in accommodation. Above a certain level of potassium, the depolarization inactivates sodium channels. This opens potassium channels, thus cells become refractory. This leads to the impairment of neuromuscular, cardiac, and gastrointestinal organ systems. And the most concerning of this is the impairment of cardiac conduction, which can cause ventricular fibrillation and/or abnormally slow heart rates. When we talk about hyperkalemia, we often think about the group of patients who are on dialysis, and specifically those who have missed a dialysis treatment. So what is dialysis? It's the process of removing excess water, solutes, and toxins from the blood in people whose kidneys can no longer perform these functions naturally. When kidney failure is present, the kidneys do not filter the blood in the same way it should. As a result, waste and toxins build up in the bloodstream. Dialysis does the work for the kidneys by removing the waste products and excess fluid from the blood. Hyperkalemia is common in patients with end-stage renal disease and may result in serious ECG abnormalities. This is because the normal elimination of potassium by the kidneys is no longer occurring, and potassium is returning to the blood, creating an elevated blood serum level of potassium. So when a patient misses even one dialysis treatment, they are at great risk for having hyperkalemia. There are also other causes of hyperkalemia which are equally as important to understand. And these causes include metabolic acidosis. In patients with metabolic acidosis, buffering of excess hydrogen ions in the cells lead to potassium movement into the extracellular fluid, therefore excess potassium in the bloodstream. A patient experiencing HHS, so hyperosmolarity induced by hyperglycemia, frequently leads to hyperkalemia, even though there may be a marked potassium depletion due to urinary loss caused by the osmotic diuresis. The increase in plasma osmolarity results in osmotic water movement from cells into the extracellular fluid compartment. This also means that potassium is moving from the intracellular space to the extracellular space. This leads to hyperkalemia. Medication can also cause hyperkalemia, often due to potassium-sparing diuretics. Because potassium-sparing diuretics do not promote the secretion of potassium during diuresis, they do not cause hypokalemia, or low potassium levels. However, there is a risk of hyperkalemia if they are used with other agents that also retain potassium, such as ACE inhibitors or potassium supplements being taken by the patient. Tissue breakdown, such as during traumatic crush injuries, can cause increase in tissue breakdown, which leads to the release of intracellular potassium into the extracellular space. Hyperkalemia can occur in this setting, particularly if the kidneys fail to also excrete the potassium. Clinical examples include trauma, which could be non-crush trauma, rhabdomyolysis. The administration of cytotoxic or radiation therapy to patients with lymphoma or leukemia, which leads to tumor lysis syndrome, and severe accidental hypothermia. And then we have the acute or chronic kidney disease. So due to the damage of the kidneys, they're no longer able to remove excess potassium from the blood. And by potassium not being excreted out of the body in the urine, potassium will continue through the kidneys and return back to systemic circulation where more potassium is accumulated. So a little did you know? Daily requirements of potassium is 1 milliequal per kilogram per day, and the average banana contains 1 milliequal of potassium per inch. So the average person who weighs 70 kgs must eat a 6-foot banana to fulfill the necessarily daily requirements of potassium intake. So when someone has hyperkalemia, we know it's not always due to a missed dialysis treatment. So what is that patient going to look like? What are other signs and symptoms that would indicate that your patient is experiencing hyperkalemia? They can experience muscle cramping, twitching, paresthesia, weakness and fatigue, respiratory distress and failure, arrhythmias, any ECG changes, palpitations, nausea, vomiting, chest pain, and even cardiac arrest. So look at those ECG changes. Here we see a normal ECG. There's a P wave, which is atrial depolarization is occurring. The PR interval 0.12 to 0.2 seconds, or 3 to 5 little boxes. The QRS complex, this is our ventricular depolarization. It is 0.06 to 0.12 seconds, or 2.5 to 3 small boxes, and there's a T wave present, ventricular repolarization, electrical activity that remains as the cardiac cells repolarize or return to their resting state. And the height should be no more than 2 to 3 times the R wave. And so this is where we want to be. As potassium serum levels rise above that high normal of 5.5, here you can see this is around that 7 milliequals per liter, you can start to note tall or peaked T waves, which are considered pathological, as is in the case of hyperkalemia. Peak T waves are the earliest sign of hyperkalemia, and here you can see they are now more than 2/3 the height of the R wave. The P wave is hidden or even flattened. The PR interval lengthens, and at times the P wave can begin to disappear. Here you'll note that the serum level again has increased around that 8 to 9 milliequals per liter. The T waves are now taller than the R waves. The prolonged QRS with wide, bizarre morphology and can develop into what is called the sine wave. This can cause any kind of conduction block, so you can start seeing a second or even a third degree AV block. And here you can see there are no discernible P waves. Once serum levels move into even higher levels, greater than that 10 milliequals per liter, this is where the sine wave or that pre-terminal rhythm is very predominant. It's a wide, bizarre QRS. The combination of broadening QRS complexes and tall T waves produce the sine wave in your ECG readout. Cardiovascular compromise and death are imminent. As the chaotic depolarization of the ventricles occur, this leads to ventricular fibrillation, pulseless wide complex, or PEA. This is the bad place. Treatment needs to happen immediately if there's any chance of reversing it. We talk a lot about 12 leads, but why would you want to get a 12 lead when the patient is experiencing hyperkalemia? Not all ECG changes are noticeable in lead 2, and by obtaining a 12 lead, we can have a better global look at the ECG changes that are taking place due to hyperkalemia. When looking at a 12 lead, here's a quick and easy way to work through a lead 2 or even a 12 lead of determining if there are any changes consistent with hyperkalemia. We'll work through step by step in the next couple of slides. First, we're going to start looking at those T wave changes. The T wave represents ventricular depolarization. This is where we're going to look and see if that T wave is 2/3 the height of the R wave or greater. Second, we're going to look at the PR interval and see if it is prolonged greater than 0.12 to 0.2 seconds, or if it's greater than 3 to 5 small boxes. Third, we're looking specifically at that P wave. Is it beginning to flatten? Is it beginning to disappear? We need to see if there are P waves with every complex. And last, we're going to look at that QRS complex. Again, normally it is 0.06 to 0.12 seconds, 2.5 to 3 boxes wide. But is it wider than that? Is it a bizarre widened QRS? Is there a combination of the QRS and the tall T wave producing the sine wave? These are indications of that cardiovascular collapse and death. So this is where we need to treat immediately. So let's look at a few 12 leads and determine if we can see if hyperkalemia is present. So looking at this 12 lead, we're going to first look for those T waves. I can see T waves in all of the leads, and they are the same height or taller than the R wave. We're going to look at that PR interval. And if you note that you can't really tell, and that leads us to the next arrow, when we look at the P waves, and I can't see any P waves throughout, so therefore I can't determine the PR interval, but we now know that there are no P waves present. And when looking at that QRS and seeing as how wide it is, that QRS is wider than the 3 small squares. So we now have peak T waves, widened QRS. Yes, this patient is experiencing hyperkalemia. Again, starting out with those T waves, you can see in leads V1, V2, V3, 4 through 6, even in lead 2, that T wave is taller than that R wave. When we're looking at that PR interval, we can see P waves that are present, and so they're borderline, as you can see throughout the 12 lead here. And we've already deciphered that there are 12 leads throughout, but they do appear to be flattened a bit. And yes, our QRS is wider than the 3 small squares. It's very noticeable without even measuring them. So yes, we have hyperkalemia present. So when we look at this 12 lead in particular, you notice that it is not normal at all. Still using that same review method, looking for the T waves. Yes, in V1 and V2, you can see that the T waves are higher than the R wave, even though it's difficult to kind of tell elsewhere. We're unable to measure that PR interval, and when looking for the P waves, we can't differentiate in most leads. When you do look at V1 and V2, we can't see a P wave at all. And the QRS, so extremely wide, starting to combine with that T wave, which means this is the sine wave. So looking at that T wave, we have a peaked T wave. There's no R wave height seen anywhere. PR interval, very hard to measure. Looking for that P wave, it's really difficult to identify any P waves anywhere. So again, hard to measure that PR interval. And then when we look at that QRS, it's very wide, but it's not quite that sine wave yet. So this is a good note about this 12 lead in particular, that patients can be hyperkalemic and bradycardic at the same time. So they don't necessarily always present as tachycardic. Let's do a quick case review. An 80-year-old female presented with a past medical history of hypertension, type 2 diabetes, a TIA, and end-stage renal disease. She's been anuric and on hemodialysis for 4 years. She presented to the emergency department due to generalized weakness, dyspnea on exertion, and mild confusion for the past 3 days. She's missed her last hemodialysis session and denied any chest pain. Her home medications include aspirin, atorvastatin, amlodipine, carvedilol, hydralazine, and argocalciferol. Her vitals include a pressure of 131/58. Her heart rate is 87 regular and strong. Those are all the vital signs we have. On physical exam, the patient seems lethargic, confused, and there is evidence of volume overload. This is the ECG, and it shows sinus arrest with ectopic atrial rhythm and intermittent junctional escape beats. So what is our assessment of this 12 lead? When we looked for those T waves in lead 2, 3, AVF, and V3, we can see that the T waves exceed that R wave. When we assess the PR intervals, in lead 1, is there a block seen? And in lead 2 and 3, there is a prolonged PR interval. When we look for the P waves themselves, AVL, AVF, and all the V leads have an absent P wave. And when we look at the widened QRS, or the QRS, it is widened globally. So the answer is this patient is experiencing hyperkalemia. Yes, I could have given it away with the dialysis, but here when we look at this ECG and how different it is, it just shows how hyperkalemia can present in different forms. Hyperkalemia is often referred to as the syphilis of electrocardiography, and it is known to produce variable ECG changes. We have to really take a look and expect anything. Taking serial ECGs is also important once we have initiated treatment to monitor the changes and the possible refractory ECG changes due to returning hyperkalemia. So we know how, we know why, and we know what we're looking for. What do we need to treat this patient immediately? Quite simply, the answer is this patient needs calcium chloride. Calcium chloride moderates nerve and muscle actions as it is responsible for regulation, release, and storage of neurotransmitters and hormones. This helps with maintaining functions of the nervous, muscular, and skeletal systems, cell membrane, and capillary permeability. Specifically, calcium chloride is essential in the transmission of nerve impulses, contraction of cardiac, smooth, and skeletal muscles, and is a function of blood coagulation. In hyperkalemia, administration of calcium chloride helps restore the threshold potential and resting membrane potential. So referring back to that inactive sodium-potassium pump, which is preventing movement of potassium to return to the intracellular space, we add calcium chloride. Administration of calcium chloride helps restore threshold potential and resting membrane potential and allows that pump to start working again. The ion pumps will open and begin to exchange potassium and sodium again. So remember that this is allowing that pump to open and start exchanging sodium and potassium again, but it doesn't fix the excess potassium in the bloodstream. Referring to the medication document M10 for hyperkalemia, let's talk first about calcium chloride. When given intravenously, its onset is 5 to 15 minutes. It's dose dependent for duration, and its effects may be persistent up to 4 hours after IV administration. It is 100% bioavailable, and it's both metabolized and excreted through the GI tract and the kidneys. When administering calcium chloride, we have to consider 2 IV push rates that are dependent on the presence of a pulse. A cardiac arrest in any dialysis patient, calcium chloride is to be administered via rapid bolus and followed by a saline flush. When calcium chloride is used in non-arrest patients, therefore the pulse is present, administration of calcium is slow, over 3 to 5 minutes, and UpToDate recommends even 10 to 15 minute slow push. Calcium chloride is a solution that is viscerant and an irritant, and it can cause significant tissue sloughing if it goes interstitial. So let's be careful. Sodium bicarb, though it has a limited efficacy in lowering serum potassium in the acute setting, even with the patients with metabolic acidosis, we don't want to use bicarb therapy alone. And this is why we give calcium chloride first when treating hyperkalemia. This includes giving calcium chloride prior to the first epidose during a cardiac arrest. Sodium bicarb is a hypertonic solution that acts as a buffer in the blood, which raises blood and urinary pH levels. Its use in hyperkalemia is controversial, but it does remain a part of the treatment that we follow. Sodium bicarb has an onset when given IV of rapid. Its effects on lowering potassium levels, however, can be delayed for up to 6 hours. When given IV, the duration is variable, anywhere from 10 minutes to an hour, and it is bioavailable of 100%. Its excretion is through the kidneys. When administering sodium bicarb, we need to consider that it is not compatible in IVs with many medications given by EMS. So it's good practice to flush adequately with normal saline between medications. It is a viscerant, so let's ensure the IV is patent prior to administering to avoid local tissue damage and necrosis. Next is insulin with glucose. They are always given together. If we are not giving one, then we're not giving the other. Insulin administration lowers serum potassium concentration by driving potassium into the cells. Primarily enhanced by the activity of the sodium-potassium ATP pump in skeletal muscles, glucose is usually given with insulin to prevent the development of hypoglycemia. So again, if I'm not giving insulin, I will not give dextrose. Intravenous insulin, typically given with intravenous glucose to avoid hypoglycemia, is to drive the extracellular potassium into the cells. The dextrose acts as a binder with potassium, and the insulin drives both into the cell. This is a dual action, so preventing hypoglycemia and potassium transport. So if your service does not carry insulin, please do not administer dextrose alone. This will only cause hyperglycemia. So normal saline is still the most commonly chosen IV fluid, but why do you think we would want to choose another isotonic solution for a hyperkalemic patient? Let's talk about lactated ringers and how it is safe to use in a hyperkalemic patient. Let's compare normal saline and lactated ringers, each with the human plasma. Normal saline, containing only sodium and chloride, is also more acidic than the human plasma. It creates an acid derangement due to the negative chloride ions. Shock causes metabolic acidosis, so by administering normal saline, we are adding another acid product to the body, and we're making them more acidotic. Normal saline-induced acidosis has been shown to directly decrease cardiac contractility and chronicity, as well as decrease the effectiveness of circulating catecholamines such as epinephrine, which can further decrease cardiovascular function. And furthermore, acidotic states have been demonstrated in animal models to significantly decrease fibrinogen concentration and impair the thrombin generation, showing a downstream effect on other systems that are critical to stabilizing traumatic hemorrhaging. When we look at lactated ringers, it has a more comparable makeup to the human plasma by containing sodium, potassium, calcium, and chloride. It is also acidic compared to the human plasma, but closer to the pH than normal saline is. It also contains lactate, which converts into a bicarbonate in the liver, helping to manage acidosis. It does not cause metabolic acidosis, and in fact, high amounts can cause metabolic alkalosis, which is far less dangerous. The more lactate, the higher the bicarbonate, the less hydrogen ions, which makes the solution alkalotic. Now, I know some of you heard me mention that lactated ringers contains potassium. Why would we use a solution with potassium when there's already too much potassium in the body? So let's clear this up. A common question is if the balanced fluids containing potassium, such as lactated ringers and plasma light A, are safe to use in a hyperkalemic patient. And the answer is yes. Despite containing potassium, these fluids will still decrease serum potassium level of a hyperkalemic patient. This is because the potassium concentration of the fluid is lower relative to the patient's serum potassium level, and dramatically lower than the patient's intracellular potassium concentration. So the results suggest that the acid-base effects of an isotonic crystalloid are more important for potassium homeostasis than the relatively small amount of potassium in these fluids. So if you have more questions, I would highly recommend that you look up this evidence-based paper. It's key that we continuously monitor these patients. We need to reassess vital signs frequently. Everything reassessed, including capnography if you have the capability. This means redoing a 12 lead or serial 12 leads. Often the ECG changes are the first sign that hyperkalemia is returning and that we need to further treat this refractory hyperkalemia. The patient needs calcium chloride. Consider your transport times and the available stock on your truck. Will you have enough if the ECG changes reoccur and you have to repeat the calcium doses? This would definitely be a reason to consider IO vascular access if IV access is difficult. Remember, a slow push if that patient has a pulse and to always flush after every dose. And if this is a pulseless patient, we are doing a rapid bolus and consider the administration of calcium chloride prior to epinephrine during a dialysis cardiac arrest. If you're at a facility that does not have dialysis capability, there will likely be an IFT immediately after to get this patient to the closest dialysis facility. So again, consider your ability to treat hyperkalemia during the transfer. How long is the transport time, and do you have enough calcium chloride? The e-document for hyperkalemia has been deleted, so for any treatment references, please follow the medication document M10. And there is also a reference document, H10, and this features the ECG changes of hyperkalemia and their time frames. If there are any questions, to reach out to our clinical team in the West Zone, here are all our numbers. We are all available at any time when you have questions. I'd like to thank you for joining us today and have a great day.